Hello, everyone. This is Louise.
Hi, Louise.
Hello. How's everyone?
We're doing fine.
Great.
What do you guys see? Do you have the internet up? What do you see?
I see a login page. For coding
Oh, good. You
now.
see the skeleton? Okay, good.
Yeah.
All right. I'm going to open up one other document just so you can all refer back to it. Actually, and I'm going to tape this just so that if you have any questions, you can go back to it. Hold on a minute. Here we go. Okay, everyone was sent this document. It says Coding Improvement Manager SIM User Acceptance Steps. Can everyone see this on their screen?
Yes.
Oh, good. Okay. So that is the login home site, the ACSCIM.com /. So the SIM works in Internet Explorer. Future versions actually may be supported. Windows 11 is going to support Adobe, so when that comes out. But not all of the browsers have agreements with Adobe to support Adobe. So it's not because of the software; it's because of the people who run the browsers, and the browsers are how you join the internet. And not all of them support Adobe, and that's one of the reasons that some of them are faster, actually. They work a little bit more exclusively for other software. Okay, so when you go in, you are in Internet Explorer. Most of you have already gotten in, though, right? I understand.
Yes.
Has anyone not been able to get in yet? If we're on the phone today, that's okay if you haven't. Just let me know.
I think I'm in.
Who's that? Who's speaking?
This is Kathy Craver.
Oh, hi, Kathy. You've been in, though. Oh, are you in the webinar, Kathy?
Yes.
Can you see the E?
It says Coding Improvement Manager, CIM.
Good. Okay. I'm just going to share both of these, though. Okay. Close this. Okay, so when you log into the Coding Improvement Manager, you see the skeleton, Mr. Bones, and some pictures. So you log in. Has anyone had any problems or questions? Your logins are not cap sensitive. Your logins are not cap sensitive. So don't worry about messing around with that. Like if you're pink 55, you can put in pink 55 however you want. So whatever your password is. All right, and so when you get in, you go to your medical records. Okay. Now, I know that Kathy Craver, how are you doing, Kathy? Are you well?
I'm doing well, thank you. How are you?
I'm good. Okay, Kathy had like a preliminary WebEx with me. We did it together on the phone, so she's been through this before. But Kathy is an outpatient coder. Now, do we have any inpatient coders on the phone?
Yes, yeah, you have 3.
Can you just give me your first name, the inpatient coders?
Jennifer?
Beverly?
Okay, Jennifer and Beverly. Let's just go over a couple steps first. All right. Now, if you, all of the cases that are in the Coding Improvement Manager are coded in inpatient. But if there's some specific issues you want to bring up, you can, do you see where the search button is on the right-hand side of your screen?
Right.
Okay. You would type in IPT. Okay? Now, these cases are coded, all the cases in there are IPT, but these are inpatient and outpatient. So if you'll see it at the end of the case that it's inpatient and outpatient. But for those of you who are outpatient coders and anybody else who doesn't want to waste any time when you get in here searching around, you can just type in OPT, okay, and it will populate all of the outpatient coded cases, okay?
All right.
Okay, now if you want to do a different search, you just reset the search, and it goes back down here. Now also, just suppose you want to do them, you want to keep your own numeric score. Some people like to keep their own numeric score of what cases they did, even though it's tracked in the testing software. But if you want to put them in numeric order, if you hit the top here where it says case ID, they'll be in numeric order. Now, if you want them in alphabetic order, you can go by case description, and they start at A. Do you see the acute myocardial infarction with HIV? So it's WPW, and it's a query and diagnostic. The second one is an arteriovenous fistula occlusion, and then atrial fibrillation. This is just medical. There's no procedure in there. But they're in alphabetical order. Do you see what I'm saying? So you can play around with this. All of your facility is PHC, which is Piedmont Healthcare. Okay? Now, I don't want to get ahead of myself, but if you want to put 5 pain cases in here, 5 outpatient pain cases, we actually now we have infusion cases that we're coding in the SIM for a different client. Like we go through every step in how to take apart the record on the outpatient side to do the CPT coding. So I don't know what your pain management cases look like and what they entail, but Larice had previously mentioned to me that she wanted to try to get some laminectomies in there too. But if there's something that's a big problem, I have had a portal through Piedmont. They do it through release of information, and they send the cases. I download them into a different computer, and they get worked on. So we have a business agreement. It's HIPAA safe. And when you see everything inside the Coding Improvement Manager, all of the HIPAA criteria is redacted or deleted. You'll see that in the record. How much different are you, Chantal, I know you guys are new to the system. How much different are your records? So you're all on Epic now, right? Or not yet, not until July?
July 1st we'll move to Epic, that's correct.
So right now I'm sorry, go ahead.
Right now we're using Meditech, and a lot of our information is dictated by the physician, and that's placed into Meditech's EMR.
And will your inpatient and outpatient both go to Epic?
Yes, we will go to Epic, both in and out, starting July 1st. Okay.
Well, whatever you decide, it doesn't matter to me what format they're in. It's just that you may want to keep them, if you're going to be looking at them in Epic, you might want to send them in Epic if you decide to send some cases, which is fine. All right, so here's a case. I'm just going to open this. It's 0025A. Now, I want to tell you, ladies, we don't have any gentlemen on the phone call. Ladies, if you see a case that says 0026A and then 0026B, they're from the same parent record, meaning this patient in 26A and 26B, they had a radiofrequency ablation, and then they also had a pacemaker put in, so we put both cases in there. So they're from the same parent case. You can't tell inside the record when you're in there, but just so you know, they came from the same parent record. Some records, like here, 0057, this one has a B, a C, a D. You know, it goes on and on. This poor person had multiple procedures, so we keep them all under the same parent. You know, that's how you know they came from the same parent record. All right. Now, do you guys want to do this biventricular pacemaker? Just go through this, or? Yes? Okay. I'm going to open it. Okay. Now, we work with something called the windmill. Now, the windmill, the first group of, you see the same document over and over again in the record, okay? But it's reinterpreted at different levels, all right? So when you go into the case, you see this little hover bar. If you click on the triangle, up, then you get your toolbar. So this case has 32 pages, but it's the same case redundantly viewed, okay? So, and actually you can play around with this to change the, the resolution or whatever you want. Now, the next step you want to take into consideration is, do you like to hover or do you want to see things on a sleeve? If you like the sleeve, open where it says comment, just click on that, and whatever you click on will populate at the top. You'll see the biventricular. Oops, there it is. Okay, so it says Consulta CRTP. So if somebody's not really sure what that is, and one of the reasons we're so detailed in the SIM is because we believe that even though we've all been reading records for many, many years, sometimes we just get used to seeing certain pieces of information that's put into the record, and we take it for granted that we know what it means. So, but if you're really wondering, we give you the formal answer of what that is, and actually it's an implantable heart failure device that provides pacing to help coordinate the heart's pumping action. It's actually just the trade name for that device. But sometimes people, I don't know if it matters to them, or, but it's always a good idea. I believe that if you're going to become a really good coder, one of the most important things is to try to understand as much in the record as you can. And I know Larissa is a good, and Elaine are both really good, mentors, and I know they know a lot about the record. But this is something that can help you on your own, okay? So everything that's in here is defined from a medical terminology, all abbreviations, everything. Now, again, you can use the pop-up, or it will populate here on the right-hand side. So it depends on what you like, okay? So we're going to go through this one. Okay, when you see, Kathy calls it the pinwheel. We call it the windmill, but I actually don't care what you call it. So when you see this pop up, it means that you're going to switch from medical terminology. We're going to go into anatomy, and everything will turn up green, and it will define the anatomy. Okay, so pectoral, right ventricular, tricuspid valve, left axillary vein, all these sites of structural anatomy is defined. We also implant pictures for you to help you. So in this case, they actually show you in the heart where they put the biventricular pacer leads. See over here, like we give you an arrow. So there's one in the atrium, there's one in the right ventricle, and there's one, actually it's on the coronary sinus vein, but it's over the left ventricle. So this helps people when you have to do, especially if you're just not sure, 3 leads were placed, the documentation's a little bit scary, but a BIV is always a BIV is a BIV. They have to put in these 3 leads. All right, now, I'm just going to go down. Okay, so there's other anatomy that's described there. They talk about the entrance site. So we actually, I'm sorry about that beeping, ladies. It'll go away. It's actually somebody calling me for a password. Okay. Okay, so then you'll see the same document will return, but it will be pink. Does anybody want to tell me what pink is going to be?
Pathways. Right there, disease pathways. Yes.
So you're going to see the same document, and you'll see imported educational material. This patient has, I think, class 4 congestive heart failure. So it goes through what that really means, because your doctors, one of the reasons we also, the cornerstone of the Coding and Improvement Manager and this type of training is that doctors are really only communicating with one another in the record. They're never going to spell everything out for you. And that doesn't mean that it's not documentation. I mean, so we actually explain to everybody what these the criteria are, and we'll identify. You'll see that it's not a part of the record. It'll pop up and say educational material. So this is the pathology. And actually, they talk about the patient's ejection fraction here very specifically. So we explain to everybody what it is, what does it mean, what's normal, what's too low. Now, we are not diagnosticians, but it helps us to understand how sick, if we should look for comorbidities in this poor patient. That's the whole goal. So here they have device failure, they have PVCs. If you see this, like this question mark, it's just reminding you that there's educational pages inside the record. So we've done the same piece of documentation from pink, and then we're going to go to blue. Now blue, we do everything we can in the explanations inside the record to give you the procedural explanation of what's going on inside the patient. So we actually want you to understand as close as we can to what happened in the op report, or if it's any procedure, any procedure that's done. And this also, blue also includes all medications and their uses, if medications are used. So the patient received conscious sedation. That's identified. Now the check marks, I checked them off here where they actually put in the 3 leads to help people. And you see there's a note on there that says the check marks indicate lead insertion. So in the documentation, it's very important to get used to the way the doctor does it. So you can really count the leads. They did get the 3 leads. This is a BIV. He wasn't drinking that day and didn't put down the wrong type of pacemaker. Okay, so this is educational materials. And actually, I think all of us have seen this in the record over and over and over again, but this identifies when you see like VVTRO, this actually explains the site, what that really means. So you don't actually, if you can understand this portion of the abbreviations, this is actually, it's a little bit complicated, but once you get it, the first letter is what chamber, the second letter is what chamber is sensed, the mode of response from the pacemaker or the defibrillator is here. If it's programmable, it's here, and if there's any tachycardia. So if it says 0, that means none. If it's paced, that means the patient, when they go into a specific type of arrhythmia, they become paced. Now, if you see S is the last letter in this, it's a universal abbreviation. That means that they get a shock. And if they have a D at the end, you know how you see DDD a lot at the end, or CD at the end, that means that it's actually paced and shocked. So this page actually explains that. All right. Position 3, position 4. This is actually, I just gave you the skinny on this, but that's what it says. So it says successful IV chamber placement. Then they got a chest x-ray to see the leads. Now, after you do blue, you go into the coding rules. Now, we talk about the rules for heart failure, tachybrady, insertion of a BIV. Show you. All right. This one has inpatient and outpatient, so it talks about both of them. So if the primary procedure code is not found in Appendix G, this actually addresses the moderate sedation when you do CPT coding, which I have found sometimes even senior coders are not always sure about whether they should be coding conscious sedation with specific cases. So this actually explains, because this patient did have CS conscious sedation, and sometimes it is supposed to be coded, which actually, it increases the reimbursement for the facility. And also, I mean, we're not doing, this is facility side, but it actually does change the reimbursement. So if you're supposed to report the CS, you should. If you're not supposed to report it, even if you write down the code, no offense, you can write it down 100 times, you're not going to get paid for it because it'll be edited out. But it actually explains, the rules around conscious sedation. And but this case, it depends on what your primary code is, and this case actually excludes CS. Okay, so, and this helps folks, again, a lot. This is a DDDR. This actually goes back to that 3-page procedural terminology documentation. So it says DDDR. So we know that it's dual paced, it's dual sensed, it's dual triggered, it is programmable. Programmable. So this is DDDR. All right, so actually from looking at that, you can become used to even knowing that if they have an atrial and a ventricular lead and if they are getting a shock or not. So after you do your coding rules, you can go into your final coding. We highlight the codes that are coded, and then you get your final page. Now, this patient has the ICD-9 and ICD-10 and CPT. So let's just go down here. These are the ICD DIAG codes. This patient has unspecified heart failure. If this was an inpatient record, that would mean you'd really have to wonder what, you'd have to find out specifically from another part of the record what kind of heart failure they had. But this is the PCS procedure for the insertion of, they got a lead in the left ventricle, the right ventricle, and the right atrium, and then they had a defibrillator, which we call in PCS a cardiac resynchronization pacemaker. It's a biventricular pacemaker. So this person, and then here are the CPT codes. Now there's no conscious sedation code on here because it doesn't apply in this scenario, and conscious sedation codes are actually decided by the primary CPT code. So that's 32 pages. Okay, let's do another one just to get you, I want to show you another OPT case. What we have. Okay, this case, PHC P0087IP, this is inpatient and outpatient. It's a robotic vertical band, or do you guys want to do the bronchoscopy with the needle biopsy of the mediastinum, or what do you can pick, what do you want? We'll do it. I don't have any preference.
Bronchoscopy.
Okay. Okay. Come on, baby. Sometimes it takes a minute for the record to load, but after you're in it, it moves fast. Okay, so we start out with red. This is 37 pages. So again, you can either use this or you can open up your sleeve and do it on the side. It's up to you. This patient is pretty sick, and this is actually a very complicated, it's a different type of bronchoscopy. So we did the red. I'm just going to show you the structural anatomy, intravenous, abdominal. Any structural anatomy is identified. Then we give you a picture here so you can see the mediastinal lymph nodes, the lung lymph nodes, and the trachea. Because, ladies, they go down through the trachea. But do you see how the lymph nodes are outside the trachea and the bronchial tubes? They actually go through and aspirate the lymph node with a puncture through the tube. through the tube in the patient, I mean their trachea or their bronchial tubes. So this is kind of a more complicated bronchoscopy than commonplace. I mean, a physician who does it and a coder who codes it. So the mediastinal lymph nodes. So I give you another picture here just for your right and left lung. And as you can see, Larice actually, who was on board with me when we first started out, sometimes the pictures were fuzzy. I think the pictures they're all crystal clear. So you can figure out what anatomy you're in. Okay. So we did green. Now we're going to go over pink. This patient has cancer, I believe. Yeah, they do. They have left upper lobe lung cancer. They start out with a lymphadenopathy, the doctor says. And he goes through all these diagnoses. They're all defined. This poor person has metastatic prostatic adenocarcinoma. They have a history. Okay. So this is some education here. If you see how it's all pink and it says education on it, that means it's not a part of the record. And wouldn't it be nice if the doctor stopped and stuck these in for you? So it actually talks about, because this patient has a metastatic cancer, it's pretty serious. We talk about how cancer is spread, what's the difference between primary and secondary. And I know you all learn this, and I know you all know this, but we try to make it as still explainable as possible, but clinical at the same time. Okay, so you begin to understand, when you start to understand how cancer metastasizes and you see the invasion and the issue, you can actually start to understand when you look for metastatic sites and primary sites, you can see relationships that are commonplace in cancer patients. All right, this is the pathology from this case. They have metastatic and prostatic carcinoma. Okay, just so you know, in each sleeve or each color section, the definition is explained once. It may be identified twice, but it's only defined one time. We don't redefine everything over and over and over again. That doesn't mean it's not for each color defined, but it's not redefined. Okay, so this is blue. This is blue. This is where we this is actually a complicated bronchoscopy, if there is such a thing. The patient has endomyobronchial ultrasound. They have let me see here. They did 150 needle passes. Okay, this is a picture of what they're doing inside the patient. So even though your patient is really having a bronchoscopy, there's a tiny little needle that goes through the bronchial tube, and they use ultrasound to identify where the lymph nodes are, and they actually biopsy them. So, I mean, this is actually, I mean, it's an amazing procedure if you think about it. Okay, so they had the needle biopsy. Then we got to go through the Wang needle aspirate. Okay, then from blue we're going to go into good old rules. Okay, there's a key here, and if you click on it, it reminds the coder to identify the specific anatomy where the bronchoscopy was done. Because some coders, by accident, make a mistake and they just think, oh, bronchoscopy, bronchial tubes. Or they see biopsy and they automatically think what? Lung, right, ladies? But this case is very unusual. This is a bronchoscopy with lymph nodes that are biopsied. So we go through all these. We actually wrote Coding Clinic to get the right codes for this one for you guys because there wasn't any specific, because this is such a cutting-edge procedure, actually. We wrote them for you. All right. Now, this is coded in PCS as drainage of a thorax lymphatic percutaneous endoscopic approach. Okay? And this is the grid from PCS. And coding clinic said to use drainage. So, I mean, I don't know if everybody would have just grabbed drainage for aspiration. But. And here's the ultrasonography. Okay, then we go through the pathology report with on inpatient and outpatient side. The rules are a little bit different. So if this is an inpatient record, we point out to you, which I know you know this rule, but we want to remind people you're not allowed to code from here. You have to find concomitant documentation in the physician record. But on the outpatient side, you better believe we're allowed to code from it. And we pointed out again, any clinical information in a pathology report may not be reported when solely found here in inpatient coding. There's actually 6 coding clinics on that, and I know a lot of people even still argue about it, which is fine, but we follow coding clinics. All right, okay. Now they talk about this metastatic adenocarcinoma. So it does sound like this patient may have another secondary site. So we remind you might have to query if you can't really identify if there's another secondary site where it might be. And then we give you the codes. So again, here you go. These are the dyad codes. And I believe that in this case, though, this is a secondary metastatic, because the way it's written, it sounds like it's a secondary from the patient's prostate. And even though they just say mediastinum lymph node metastasis, it's secondary. And the poor person has a history of prostate cancer, and it doesn't look like there's any concurrent treatment or residual treatment for the prostate cancer anymore. And unfortunately, prostatic cancer is one of those cancers, in the pink it tells you this, that even if cells are left behind, it can metastasize to other parts of the body within 4 years. So patients who think that they're in remission and have no more prostate cancer, unfortunately, they wind up with secondary cancers in other sites of their body, particularly bone, lung, and lymph. So it happens. So, and the only reason I know that is because I just learned a little bit of pathology. And so what's important is to know these facts, especially if you have to query a physician. We are not doing any diagnosing. We're still trying to get them to write the facts, but we should understand what they're talking about. That's our whole goal here. So here's your CPT codes with the EBIS. Did you have a question? I heard somebody peep. No? Mm-hmm. Okay. So suppose you want to do your CE credits. You go test me on this. All right. This is the Coding Improvement Manager quizzing and testing interface, and it reminds you that you can't log back into the case. And this is actually set up intentionally like this because, I'm not, but they don't want anybody cheating. Not that you would cheat. And you have 9 tries to take the quiz, so it's not as though, and it doesn't matter if you do have to attempt it 5 times. It just means that you might have learned. What happens a lot of times, I found in the past about coders, is they learn things wrong, unfortunately, from other people. So what we're trying to do is get everyone to learn the facts from the sources. So it has 6 questions. You guys want to help me with this? Inpatient coders may directly code from a pathology report. Is it true or false? False. Okay. When coding a bronchoscopy with the fine needle aspiration of lymph nodes in the mediastinum utilizing the EBIS, you need 2 codes for CPT code and 2 codes for PCS. It is not possible for a patient to have a transbronchial biopsy in the mediastinum during a bronchoscopy. That's absolutely false. See, a lot of people think that's how could that happen? That's what the whole point of the case was. All right, this is a pathology case. How does cancer metastasize? Direct extension, lymphatic and lymph nodes, blood vessels, all of the above choices are correct. C. If a tumor originates within specific tissue and proliferates or grows, what do we call that? Let's say primary. All right, the correct approach character for the bronchoscopy with the fine needle aspiration is percutaneous endoscopic. I think you guys all know that if you've had any PCS training. Oh no, I'm going to submit. Well, you can review your questions and change your answers if you like. All right, you can actually still exit the exam, but you won't be able to get back into the case till you submit an exam. So we'll submit an exam. Here we go. Oh no, what are we going to get? We got 100. Okay, so then, but if you don't, you know what? I actually recommend this. Take the quiz before you do the case. Take the quiz first because some of it's hard, and it doesn't mean you're cheating. It just means you'll look for specific. Because this is trying to get you to think more like a coder. We don't want you to think like a nurse or a doctor. We want you to think like a coder. So then you get a certificate. Here it is. And see, it'll come up here. Your certificates will all be in a row here. And then you go like this, download your certificate. You open it. Oh, there's the case. So you get a CE credit or half a C. Some of them are 1, some of them are 2. Now you can save this to your share drives if you guys have a share drive. I don't know how your facility works, and I don't know if you're allowed to print. You can either save it or print it. But it will also stay in your exam builder. Okay? I'm just going to exit out of there. I'm always trying to I take every quiz before I put one in here so that that's why I have so many certificates. So now suppose you want to go back and do another case, you can just go either to medical record or back. And you're back in, starting all over again. Does anybody have any questions?
Great learning tool. It's a great learning tool, Diana.
Thank you. Is that Chantel?
Yes, it is.
I take that as a severe compliment from you. Elaine, actually, I'm going to tell you, I'm going to become nostalgic here because I have like a, I have a lot of affection for Elaine and Larice. But they found me at the AHIMA conference when I spoke, and they picked the software when it was in the alpha stages, and now we're in phase 2. So, it really does work. You just have to use it. Everybody, if you use it, you'll learn so much in every case. And the CEs are free. And it doesn't. And if you need more than 9 times, or if you have any questions, email me. And I'm not kidding. I will respond to your email. We'll get it straightened out. If you think a question is unfair, anything you think, I want your feedback.
Well, thank you.
You're welcome.
Do you have any questions, coders? Questions, comments?
Did you say that you would reset it if we emailed you? If
you needed more than 9 tries, and I'll tell you, of all the Piedmont employees that have been taking quizzes, nobody has taken more than 6.
Okay.
And we do generate reports to your administration, but there's nothing in there about how many times you took a quiz, and it just says you're in there. It doesn't say. I mean, when you're in here, it's private, but we do generate reports to prove that you're using it. Just so you know, everybody should know that because actually we had one coder from another group. She insisted she was in there, but she didn't take any quizzes, and it turned out she was.
Mm-hmm.
Hey, this is Elaine. I just want to add to what Diana has stated to encourage you to use it. A very good tool to teach you, especially for cases that, PCS coding is very challenging and we're not familiar. You may not be familiar with some of the other cases that you may be asked to code at the other Piedmont facilities. So it's a great tool for you to go in and practice and learn how to code those diagnoses and procedures. I wish I had something like this when I first started learning to code. So, while we have this tool available, I would encourage you to use it. If you have any questions or you need additional help, I'm offering Larice and my team to be available to assist you. So don't be shy about, saying I don't know how to use it. Can you help me? We'll be glad to do that.
Thank you.
Okay, well, if you have any questions after this, just email me. I don't want to take up any more of your time. And I appreciate your logging in, everyone. I sincerely do.
Yeah, thanks a lot, Diana.
You're welcome. Take
Thank
care.
you.
Bye, ladies.
Bye, Diane. Take care.
Bye,
Bye, everyone.
Thank you. Bye-bye.
Bye.